So thanks for joining us. We're excited to share all of our information with you. It's mostly going to be like a sampler platter of different topics to give you an idea of what pelvic floor physical therapy can help with and what different types of conditions we can help. So the big three are pregnancy, postpartum, and Sarah is our in-house pediatric specialist who can help with pelvic health as it pertains to kids. So I will start with the pregnancy stuff. So these are the topics that we're going to discuss today. Just some quick tips on how to manage common discomforts. A lot of that is related to the postural changes with pregnancy, pain management, and then core strengthening. A little bit of background on how to do that and how to manage as the belly grows. Oh, it blinks at me when somebody's in the waiting room. I don't know if it blinks for you guys. Anybody see that? Okay, so you can let people in. Okay, so postpartum, there it is. Postpartum, these are the topics that Linda's gonna go over. So how childbirth affects the pelvic floor, and then early recovery and some common symptoms people experience then. And then Sarah's gonna talk about bladder issues with little baby kids, and so how the bladder works, healthy bladder habits, some common symptoms and difficulties with that. All right, so this is a visual representation of the most common changes that we see during pregnancy. Obviously, as the belly grows, the abs stretch, and that tends to put pressure on other structures. So the biggest thing to take note of is that the spine, the curves of the spine become accentuated. So as you can see in the first photo, that's more of a neutral posture, and then towards the end of the pregnancy, things become a little bit more S-shaped or pronounced. And what that does is it places excessive strain on different tissues. So with more curvature of the spine, you notice that the head comes a little bit more further forward. And then the pelvis itself, which is shaped like a bowl, tends to tilt more forward, which then accentuates the dip in the low back that naturally is there anyway, just becomes a little bit more pronounced. So with that, you can have a lot of back pain, hip pain, even some head and neck issues like headaches and TMJ or jaw issues. Which is something not everybody thinks about, but it is commonly related. And then if you look at the second image, you can see the rib cage and how it goes from a nicely kind of compact position to a fanned out or flared position. And part of that is because of the increased pressure from the growing baby that elevates the diaphragm and pushes the rib cage out. So by the end of the third trimester, you actually have less breathing capacity from the diaphragm because of how much pressure is pushing upward against it. And then thinking about lower towards the ground, you usually see a wider base of support with the end of the pregnancy because of the changes happening in the pelvis and changes with gravity. Usually it's just easier to stand with a wider base of support for just for endurance and all of that. So you also see kind of like that waddling type of walk that happens towards the end. But what that does is it places an increased demand on the stabilizing muscles and tissues of the hips, the feet, the ankles, and the groin. So all these things are natural and they happen mostly towards the end. And you will see some common discomforts, and what you can do to help with those things are to kind of think about what's happening and almost try to reverse it, not in a rigid way, but more so in just an awareness way, and trying to do things to narrow the base of support, or at least practice doing that. If you feel like you're slouching or your head's coming forward a ton, working on exercises that are thinking about things that open up the chest and flatten the mid-back. Even some nice rotations for the upper back is helpful to do to keep the mobility up there. And then the common discomforts, okay, they're listed here. So common areas of pain during pregnancy, obviously the low back and the pelvis, that's just a given. So you have some pain in the back, in the spine, or you can have it in the SI joints, which are the joints that connect the pelvis from behind. So I took this from the clinic today so that we had it. So this is the front of the pelvis, and there's the pelvic inlet, and then underneath is the pelvic outlet. And then from the back view, you can see that the sacrum, which is this piece of bone here, gives rise to the spine and connects to either side of the pelvis or the hip bones. So these joints that connect the two can be a source of pain, and that's usually when you are transitioning from either sitting to standing or from one leg to the other, because that's where all the force from gravity and from the ground comes through. And then in the front side, you have the pubic bone. So the pubic bone is actually fairly large. Everybody thinks that the pelvis sits in the body like this, but it's more so tilted slightly forward this way. So the pubic bone creates almost a shelf for the bladder and the pelvic contents inside. So again, because that's where the front side of the pelvis meets, anytime you're transitioning from one leg to the other or from one position to another, you have that dissociation between the legs. So there can be some pressure and some pain along the pubic bone. And again, I mentioned earlier that the head and the neck are involved with those changes in the spine. So you might see some increased headaches, you might see some jaw pain. A lot of that is from the head coming forward and how that puts a lot of pressure on the muscles in the back of the head. So you can massage the head, you can massage the jaw, but it really comes down to kind of correcting that posture in the mid and lower back to undo that forward translation of the head. And then moving towards the outer body parts, so feet and the hands, people kind of forget about those, but it's not uncommon to think or to see plantar fasciitis, which is pain usually at the heel or at the bottom of the foot. And again, because of the widened base of support, that creates widened stance. So now you have a lot more pressure on the arches of the feet. And without proper hip strength and mechanics up the chain of the lower half of the body, you can see excessive strain on the plantar fascia. And then things like carpal tunnel are also a thing. If you've heard of mommy thumb, that's a euphemism for a strain of one of the tendons in the wrists along the top side of the forearm. So those are fairly common. Carpal tunnel has more to do with the swelling and the increased fluid in the body during pregnancy, which can create pressure on the nerves and cause some numbness in the hands. So same thing can happen in the feet. And then management for these things. So it's really hard to just give a blanket statement of how to address symptoms and discomfort across the board because everybody's anatomy is so different. But just on a general level, for the low back and the pelvis, you really want to think about keeping flexibility above and below the low back and the pelvis because that's already so flexible throughout pregnancy. So keeping the upper back mobile with either foam rolling or stretching for the shoulders and the chest, rotational stretches, upper mobility, and that kind of thing. For the head and the neck, again, I talked a little bit about the posture already, but making sure that we try to reduce or minimize how often our neck is coming forward. So strengthening the muscles of the shoulder blades and the back, the mid back is going to be helpful for that. And then for the feet and the hands, you want to just strengthen around the hips and the core, make sure you're keeping good posture, and then using compression garments as necessary, which I'll talk about in the next slide. And then just modifying activities. So going upstairs, you might want to take half the flight and then take a little bit of a break and then do the rest of the flight. So depending on how far you are into pregnancy, sometimes it just takes a little bit of cleverness on how to adjust whatever it is that you're doing. Okay. So if we go on to constipation. So constipation is definitely common in pregnancy. Part of that is due to hormones. So the hormones slow down mobility through the intestinal tract, and metabolism also changes. So the other common causes are dehydration and differences in dietary intake. So different foods can change the consistency of stool, which can make it harder to pass or just slowed in general. Symptoms include straining on the toilet, so holding your breath, pushing really hard, taking longer than 10 minutes to empty, like things just aren't coming out smoothly, or the consistency looks like pebbles or hard cracked stool. So there's a nice chart right there called the Bristol Stool Scale. And ideally you'd have your bowel movements close to a type 4. So that's when it's formed, but it's soft and it's smooth, versus types 3 and 2, which are a little bit more cracked. And then types 5 and 6 and 7, which are a little bit fluffier or almost to the consistency of liquid. So if you are closer to a 1 or a 2 or a 3, that can be a sign that you're constipated. And then one more other symptom that's common in pregnancy is hemorrhoids. So this may or may not be related to constipation because there's just so much more blood produced in the body during pregnancy that the veins typically swell, especially around the perineum or at the base of the pelvis because of all the pressure. So that might be there just in general, but definitely if you are constipated and straining, then hemorrhoids can be a common side effect of that. So chicken or the egg with the hemorrhoids. Management of constipation during pregnancy includes improving the consistency. So if you can get it to be less of a type 1 or 2 and more of a type 4, that'll already help with at least the passing. And the way to do that is to look at your fluid intake. So how much water are you drinking, and what kind of foods. So at the clinic, we give a list of foods that either thin the stool versus thicken the stool. So things that thicken the stool would be your starchier foods, your high fiber foods like oatmeals, rices, pastas, breads, versus the foods that thin the stool, such as leafy greens, dark chocolates on there, which everybody's a fan of. Red wine also thins the stool, and sometimes caffeine can also help with that. So depending on what you like to eat and what your routine is, you might want to just consider kind of balancing out how many laxative foods versus how many constipating foods you're eating. And then squatty potty. So we're big fans of the squatty potty. So one thing that helps with emptying the bowels is making sure that you're set up for success on the toilet, which I'm sure Sarah will talk a lot about for the little kids too, because childhood constipation is also common. But definitely want to set yourself up so that you're relaxed and your feet are supported to the point where your knees are higher than your hips. So basically you're in a squatting position without holding your legs up physically, by bringing the ground up to you through a stool like the squatty potty. And what that does is it places your pelvic floor muscles in a position where they can relax a little easier. So that also helps with emptying. And then for the bladder, one of the common or a few common symptoms during pregnancy is obviously urinary frequency, a little bit of urgency, and maybe even some leakage. So all these things, depending on the person, there are a lot of reasons why they happen, but the most obvious is because of the pregnancy. There's all this pressure on the bladder, right? So with a growing baby, the bladder has a little less room to stretch and fill. And also when it is full, there's something on top of it trying to push things out. So give yourself a little bit of credit with this one, because sometimes it's just a matter of pressure and gravity. But needing to void frequently, so more than every 1.5 to 2 hours in between leakage with coughing, sneezing, laughing, or that's triggered by either the sight of a toilet or the restroom, or hearing or seeing running water is a common complaint. And then also feeling like you can't fully empty, or you feel like you're done and then you stand up and then more comes out, or to get the flow started, you have to really push or strain to void is also common during pregnancy. Again, everybody's a little bit different. You may have one or more or none of these, but the management for these is to make sure that you have good bladder habits. So emptying regularly. So anywhere between 2 to 4 hours is ideal. So you want to hold for 2 hours at least. You can get to 4 hours usually, but that's on the tail end where the bladder is usually a lot more full. So it's definitely harder. So if you look at that image on the side there, you have a cycle starting at the top photo where the bladder is filling, and then as the bladder stretches, it sends a signal to the brain that there's something in there, it needs to empty. But usually that first urge, or I call it a knock on the door, is just that the bladder is maybe around halfway full, a little less than that. And as it fills, then the brain warns you again that, oh, it's a little bit more full, there's more weight here, there's more pressure, which is where you see that transition from the bottom picture to where it's really full to where it empties on that left-hand side. So you want this cycle to happen over the span of 2 to 4 hours, but that can obviously change if you're drinking a ton of water, or maybe if you are stuck traveling and you have to hold for longer than a couple of hours. So there's some wiggle room there, but ideally 2 to 4 hours to keep everything happy and your pelvic floor muscles happy, because the longer you hold, the harder your pelvic floor has to work. And over time, that can also cause some issues of overactivity. So to manage any leakage, people usually think of Kegels, which may or may not be true, because Kegels are just one function of the pelvic floor muscles, which is when they squeeze. But if you think of emptying, the pelvic floor muscles actually have to relax. So you want to train both strength and flexibility, and coordinating when that's supposed to happen. For example, when you're coughing or sneezing versus if you're on the toilet trying to empty, right? So 2 different things, but same pelvic floor muscles. So if that's something that's an issue, that's one of the things that we can evaluate with you during a pelvic floor examination to make sure the muscles are doing what they need to do. Because again, everybody's a little different. So that's the bladder. And then for pain management, so we talked about back pain, some hip pain, some pubic bone pain. Again, it's really hard to give just a generalization of what can help with pain during pregnancy because it's really, it depends on the individual person and how the symptoms behave. But two of the things that we give almost every pregnant person that comes in is teaching them how to activate their transverse abdominis and activate their pelvic floor, both to squeeze and relax. So if you look at that bottom pair of images, those two people laying down, I guess it could be the same person. On the left side, you have somebody inhaling or taking a deep breath in, and you can see how the trunk, which is made up of the abdominal wall, the pelvic floor, the spine, and the diaphragm, everything kind of expands like a balloon filled with air, and that creates a relative downward pressure on the pelvic floor. So if you right now take a nice deep breath into your belly and let everything expand, hopefully you feel your pelvic floor muscles release. Then as you exhale, think of how a balloon deflating would shrink together. That's when you'd want to do a Kegel or squeeze as if you're stopping the flow of urine. So as that happens, inhale to release some pressure or to increase the pressure and release the tension in the pelvic floor. Exhale to squeeze the pelvic floor and do the Kegel as everything shrinks together. So if you have trouble doing any of those two, or maybe you have a hard time feeling one or the other, that's the type of stuff that we go over in a pelvic PT session to make sure that you understand and have the confidence in how to do that properly. Now for the TA or the transverse abdominis, we definitely want to engage those muscles because they are at a disadvantage just by the stretching of the baby. So a couple of things that we give people to think about is tensing the belly muscles as if they're putting on a tight pair of pants. So if you look at that image on the top side, on the right, you can see that the belly goes from relaxed and nice and soft to just gently pulled in and flattened inward. So we tell people to imagine hollowing out the belly or shrink wrapping the belly in. It's different than a crunch, it's different than tucking your pelvis, and it's different than doing like a sit-up. It's very subtle, and the muscles basically hug inward and pull towards the spine. I usually tell people to imagine what it's like when somebody's going to tickle you and you pull your belly muscles slightly in. It's that inward pressure. So you can practice that during pregnancy, and I think it's actually easier to see this on somebody who's pregnant because we tell them hug the baby. So when you hug the baby in towards your spine and up towards your ribs, you can see that movement, and it's really subtle. And then when you let it go and you inhale again, you see the belly expand. So combining that with the pelvic floor, right before you do anything that's transitional, so before you get up out of a chair or before you turn in bed or before you go up a step or down a curb, you can gently hug the baby in and engage the pelvic floor and start trying to time that and see if that changes your pain, because then that gives you more of an idea of if it's a weakness or a stability issue. So just one thing that you can start to try to do if you're pregnant, and then if you have any confusion or questions, definitely consider talking to a pelvic PT about that. So last thing is for pain management is you want to have the option of having some external supports if you are able to get your hands on them. Belly binders are good for later in the pregnancy when you just are so tired and you don't have the endurance to do a ton of exercises, and you're just on that tail end of that last trimester. So a couple of good ones. The tan one is called the Better Binder, and it has those two straps. And then the one on the left, I forget what it's called, but it has the giant underbelly wrap and then the top strap to connect it. Both are very comfortable. It's a personal preference, but these are great because as the belly grows, you can just adjust the two pieces or the two straps to make it comfortable. The bottom one is a SI belt or a sacroiliac belt, and the brand is Sorolla, and that goes around the pelvis. So you don't want it to wrap around your low back up here. You want it to wrap mostly around the pelvic girdle to, again, support everything in. As hormones circulate and makes this all really loosey-goosey, the belt helps to provide a little extra stability just throughout the day. So that's another option. And then really consider compression garments for all the swelling. So they make there are socks, I believe, that you can wear on like airplane flights so your ankles don't get too puffy. Same thing for pregnancy. If you know you're going to be on your feet a ton, sometimes that's really helpful. And then for footwear, again, because of that widened base of support and the tendency to put more pressure through the arches, a lot of people don't think about their flip-flops, because I know at least here in Southern California, everybody's in flip-flops all the time, but those don't have the greatest arch support. So using or changing up the footwear, depending on what you're doing, to be supportive versus really flat. And then bra selection. So this is more for the bras that are, I guess they're the dressier bras that just have the 2 straps above it. Just thinking about how much the breasts develop during pregnancy and how much the spine curves. Sometimes just changing the bra is a great option. So bras that have more fabric on the back, so that racer back type of style where it can spread a lot of that support across the back versus on the straps, is something that a lot of people don't think about that can help with any upper back and neck pain. So yeah, different options depending on where you're feeling any symptoms, and talking to one of us. If you're experiencing anything specific, we can help guide you in the right direction of what to consider. So I think that's it for me. So I'm going to pop out of here so Linda can hop on. So where's Linda?
Alrighty, I'm right here. Let's see. Okay, can you guys see that screen right there? Perfect. Okay, so postpartum, some things I'm going to be talking about are effects of childbirth. So we'll be going over vaginal birth, C-section, and a VBAC. We'll talk about a little bit about early recovery following delivery for both, as well as some common signs and symptoms you'll see following delivery. So first off, pelvic floor anatomy, really quick, just like what Q talked about. The bottom of the pelvic floor has 3 different layers of muscle, and I tell people to think about each layer has their own jobs per se, but they all work together for bowel and bladder function. Keeps everything up and in while we're sitting here and listening to this presentation, lets everything out when you're ready, whether you are at home in the restroom or in the woods, whatever of your liking. And then it helps with sexual activity as well as labor and delivery. So looking at how it kind of closes all of these sphincters for your anus, the vaginal canal, as well as the urethra, that's going to play a really big role following postpartum. So let's talk about vaginal birth. So effects of vaginal birth, there may be certain things that, this is not an all-inclusive list, just kind of major things that we see in the clinic. Perineal tears are very common. It is the space between the back of the vaginal canal as well as the anus. So if you look at the diagram to your right, there's 4 different degrees of it, and each degree is essentially named for how far the tearing has happened. First being just skin, 4th being a complete tear from vaginal to anus through the sphincter and into the rectal lining sometimes. If you look at the second little line, it says episiotomy. So currently speaking, episiotomies aren't very commonly done anymore. There's been a lot of research saying natural tears have a less likelihood of increasing the amount of tearing. So there is that, but it is dependent upon your OBGYN. So it's something to talk to your healthcare providers about. And on there, you'll see something called pelvic organ prolapse. We'll talk about that, I think, in the second or I think 3rd week. Essentially, in a quick snippet, it is just people will talk about feeling some sort of heaviness from the vaginal canal or a balloon or something protruding. It is essentially the pelvic contents, whether it is your bladder, your uterus, your rectum, kind of pushing forward into the vaginal canal, secondary to increased pushing time and all of those things. Tailbone pain. Tailbone pain is very big during pregnancy, as well as following for vaginal birth, sometimes because of the amount of pressure and pushing. For the clinic, we usually will have at 36 to 38 weeks, we'll do something called labor and delivery positions. So we will actually set a woman up and check her pelvic floor as to what positions they're more comfortable in. Essentially speaking, that you want to make sure pelvic floor is actually relaxed when you are in the pushing phase of labor and delivery. Okay, so then diastasis recti, in short, people call it a DRA. It's where you see a little bit of abdominal splitting because the belly has no more room for baby, and body has to make a decision whether it's aesthetically pleasing or baby growing, and generally speaking, it is going to be baby. Baby always wins. You'll see a little bit of bowel and bladder dysfunction just because of the increased stretch of baby's head when they crown, as well as shoulders when they come through the vaginal canal. So there's that. Something to also think about too is pain with sex. It could be secondary to vaginal soreness from delivery, or any scarring or from the episiotomy, or any tearing. So this was a really neat little visual for cesarean sections. So I'm going to move on to C-sections. So we always talk about C-sections being kind of normal or whatever it is, but this is just a really good animation as to how many layers they actually cut through. So you'll see skin, fat, fascia, which is like tough fibrous lining. That's your abdominal wall, and you'll see the linings cut up and down. Peritoneum, which holds the organ and cavities, and then you'll see your uterus and your bladder. They'll remove the bladder back, cut through the uterus, there's the sac, and there's your baby. So looking through all of that, it's about 7 layers of tissue that is cut through in order for us to get to baby. So something to think about for C-sections. Now, postpartum effects of C-section. So risk of infection, just because it is a surgical procedure, there is a high risk for healing, how the incision does. There is scar tissue and adhesions that we have to think about, because looking at that 7 layers, they have to sew back down those layers. So looking at how the body kind of scars down to protect itself. Some women may talk about abdominal pain, sensitivity, some numbness or tingling in that region. Again, the diastasis recti is really big just because of the lack of abdominal strength when baby is growing and abdominals are so far from the body. Now, looking at lower back pain, there is a risk of bowel and bladder dysfunction, as you can see, because when they have to make that incision all the way down through the peritoneum, they have to move the bladder back a little bit. There is a chance that if it is your first, second, or third cesarean section with scar tissue, there may be some adverse effects to that. So let's talk about early recovery. So baby is here. Some things to think about for moms: wound care. If you had a vaginal birth, oh, I'm sorry, VBAC. For some reason, I guess the screen cut out. So VBAC is a vaginal birth following a cesarean section. It is possible if it is, there are different criteria depending on the hospital as well as your OBGYN. So a conversation to have if you had a C-section for the first child, first or second child, and you want to try a vaginal delivery. The pros of it is that it's a shorter recovery time because you don't have to go through another surgical procedure. The risk of surgical complications are much lower. However, there are things to look at in the sense of, again, scarring. How much scarring there were are there any complications with umbilical uterine rupture and placental rupture? So again, conversations to have. Early recovery, sorry. So then vaginal birth, we want to take care of the perineal tears. So making sure we keep everything nice and clean, nice and dry. Generally, you can come home with those little squeezy bottles that have a little hook tip to clean the area to make it a little bit more comfortable. Making sure C-section scars are, again, clean, dry, and you're changing dressings. Then you have to think about posture and mobility. Following delivery, everything's a little more painful than usual and a little bit more sore. So like Hugh said, postural awareness. We went from super pregnant, super kind of in whatever position pregnancy is, to now no belly, and all of a sudden breasts are engorged because you're breastfeeding, and now you're feeding a lot, which puts us in this really curled and hunchback position. So understanding how to open up through there and getting, like Hugh said, some better support for the breast, as well as looking at bed mobility. So that's a really big one. Baby cries, we're tired, but making sure you're not getting up like a sit-up. You want to make sure you roll to protect your incision, whether it is abdominal or vaginal. Transfers are things like sitting to standing from a chair, getting in and out of a car. Again, those are things that we go over in clinic in the sense of how to protect your wounds and how to protect your back and your abdominals to make sure that you are transferring successfully with decreased pain. Lifting and lowering, we do this a lot following delivery because there is a child now. So understanding mechanics and how to lift and lower from the hips or the knees using your abdominals and the TA that Q was talking about to make sure we're protecting our spine as well as our pelvic floor. Support and strengthening. So the abdominal binders for pregnancy are a little bit different than the ones following delivery. There are some that you can buy that I think will make for both. The big one that we don't know the name of that was in the top left corner when Q showed us, I'm sure I can pull up a picture later if someone's curious. It goes right around the abdominal region. It just acts like a good corset, and it gives that abdominal region just this big hug, so we feel a little bit more supported in the early stages of recovery. So strengthening of pelvic floor and core strengthening. So in the next slide, we'll talk about common symptoms, but pelvic floor, looking at the Kegels, do you need to do them because they're a little bit weak, or is it now overactive because it went through something a little bit more traumatic? So some things that we look at as well. Core strengthening to make sure low back and everything is nice and taken care of. Lastly is functional mobility. We're all very big with this in the clinic just because, again, lifting and lowering is very big following delivery, because the amount of times we feed the baby and the amount of times we have to change baby, skin to skin, and nursing and all of those things. So we'll go over mobility there, and then breastfeeding techniques. So a lot of the times the mommy thumb actually comes in maybe later down the line when baby is heavier and we're lifting them this way. However, I just actually spoke to a patient who was feeding with her hand under the head, and then she was always turning the baby's head toward her breast because baby wasn't latching the way she wanted to, and then she developed the mommy thumb. So again, some things to think about mechanically when we are nursing, and we'll talk about positions to nurse that is easier for mom as well as more productive for baby. Okay, so last one, common symptoms. So these are just kind of a running list. Again, not all inclusive, but common symptoms we see following delivery, whether it is vaginal birth, C-section, or a VBAC. Urinary and fecal incontinence, a little bit of leakage, which we'll talk about, I think, next week. I think next week's bowel and bladder, so tune in for that. Overactive bladder, like Hugh said, where the brain just kind of goes, oh, I need to go now, I need to go now, I need to go now, versus knowing that the bladder can hold anywhere from 2 to 4 hours. And then constipation is really big following delivery, just because of medication, if you got an epidural or there are pain meds or whatever kind of is happening. There's a lot of hormone changes happening. Hemorrhoids are one of those things that we see as well because of pushing. So that's something we will talk about, how to lengthen pelvic floor so we don't increase any hemorrhoids when you have a bowel movement after baby is here. Vaginal heaviness, we'll talk about the pelvic organ prolapse, but that's one of those symptoms that a lot of women will come in with, saying they feel like something's falling out of the vaginal canal, where it's just a lot of the pelvic organs pushing through the vaginal region. Vaginal dryness, some women will experience due to, again, the major hormone changes. There are some things you can talk to your OB about to kind of help with that. Perineal pain because of either tearing or soreness from pushing and from having baby come through the vaginal canal. Scarring is a really big one, whether it is a vaginal birth or a C-section. So making sure the scar is moving the way we want it to, and it's not super rigid or keloid, because that will lead to other issues such as adhesions or pain. There will be some numbness and tingling just because they do have to cut their nerves anytime we have any tearing or cutting through of any tissue. And then we'll talk about a little bit about pain with intercourse is one of those symptoms as well. And it usually will subside, but sometimes because there is scar tissue at the perineal region, that is what causes the sensitivity and the pain. Lower back pain, abdominal pain and sensitivity. Abdominal weakness is a really big one just because we were pregnant for 40 weeks. So then looking at hernias, umbilical hernias, inguinal hernias, those are also very common sometimes when it comes to where we were strength-wise prior to delivery, as well as prior to pregnancy. And then looking at the bending and lifting, which is a really big part of postpartum care. Hypersensitivity to the skin. We also look at clogged ducts. So people talk about mastitis and making sure you're feeding on both breasts. So those are things we talk about, as well as swelling. So compression garments will be really good for the weeks following delivery, just to kind of keep everything held in and moving. So next we have pediatrics.
All right, everybody. So let me get my screen up and my video on. All right, so I'm going to be talking about pediatrics, including normal bladder function in kiddos and healthy bladder habits, and then some of the common problems that we would see in children in pelvic physical therapy. So things like bedwetting, daytime leakage, overactive bladder, and dysfunctional voiding. So just as a review on how the bladder works, the bladder is meant to help fill and store urine. Urine comes from your kidneys. your kidney's job is to help to filter out your blood, to help with chemical and fluid balance. So urine is the waste product. It comes, it fills your bladder starts to stretch. This is the normal function. And once your bladder reaches a certain capacity, that's what triggers your brain to tell you that, hey, it's time for me to go to the bathroom. I need to get going. So that's when you make way for the bathroom, sit down on the toilet, and then once your brain knows it's in the right position and right time, then it's going to, your pelvic floor sphincters are going to start to relax. Then your bladder is going to start to contract to help empty your bladder out. Once all the urine has been emptied, then your bladder can relax and your pelvic floor starts to contract again. And it's worth noting that even after your bladder is empty, so to speak, it's not always fully empty. So there's always a small amount of urine left over after we finish voiding. So that's how a normal bladder should be functioning. But obviously with infants, those are skills that have to be developed by the body. So in infants, the bladder doesn't actually stretch very much. As soon as it starts to fill with urine, there's a reflex of the bladder that just squeezes the urine right out. So there's really no capacity of the bladder, and that's why infants tend to urinate so frequently. But with time, the sphincters and the pelvic floor muscles start contracting. When those muscles start contracting, then that helps to teach the bladder that it needs to actually stay relaxed. So these two areas, the pelvic floor and the bladder, are actually antagonists. They don't like to work at the same time. They need to be working opposite of each other. So that's something that the body is developing in infancy. And just like with muscle development of your hamstrings and your quadriceps, it's important for your bladder, which does have a muscle in it, to learn to store and stretch as well as contract. So that's one reason why it's really important to have good fluid intake, is so that way the bladder is learning to store and stretch, and then when it's time to go to the bathroom, it will contract and squeeze everything out. And so by age 4 or 5, the bladder has actually quadrupled in capacity. So that's why the frequency of urination can go down. It's usually not every hour like it would be in an infant. Then by age 3, you can really expect full voluntary control of urination, meaning that the brain is more in control, the person is more in control of what their bladder is doing. And then it's not until age 4 that we can really consider that the child is going to be actually independent to toilet all by themselves, meaning get to the toilet, undress themselves, sit on the toilet, go to the bathroom, then stand back up, dress, and flush the toilet and wash their hands. There's a lot of process that has to go on. And so by age 4, we really are going to consider that that child's going to be independent in that. So for pediatric norms is in terms of how often we are going to urinate. In the first year, it tends to be about 20 times a day or hourly. Because remember, the bladder is not storing anything really. Then in ages 1 to 3, it tends to be about 11 times per day, but remember the volume is starting to increase. So the urine production is increasing, obviously with increase in size of the child, but the bladder is also storing more and more. So each void is going to be a little bit bigger. And then by age 12 is when we're really going to expect to be the child to be more at an adult normal, which is about 5 to 8 times a day. So with nighttime control, usually after a child is dry during the day, the nighttime will follow about 10 months later. It's usually fully developed by age 5. But about 10% of 6-year-olds still leak urine at night. And we're going to talk a lot more about bedwetting in a little bit. So good habits, hydration is really, really important for everybody, not just for kids and pregnant women, and it really is important for everybody. So with children, remember, we're trying to teach them that their bladder needs to fill and empty. So kids need to be drinking throughout the day, and we recommend 6 to 8 drinks a day. Now, that amount is going to change. Obviously, you're not going to be giving a 3-year-old a giant glass of water. So we tend to figure that for the total amount of hydration per day, we want about 1 ounce of water per kilogram of body weight, or take a person's body weight in pounds, divide it in half, and that's how many ounces that you're gonna want to drink. Water is best for hydration, but it is okay to dilute fruit juice, like apple juice and white grape juice tend to be the most friendly on the bladder. We tend not to include milk in this hydration. Obviously, milk is still good. It's nutritious. We're not saying don't drink milk, but I wouldn't include it in the actual fluid intake. Dehydration for anybody really, it's going to lead to poor stretch of the bladder, which means the bladder's not going to have a great capacity, so it's going to be a lot more overactive, most likely. Dehydration is also going to concentrate the urine, which makes the bladder more irritated, and therefore you want to go more frequently. So it's really important to make sure that your kid is getting plenty of water throughout the day so that bladder can stretch and empty, but also to make sure that urine stays with good concentration. So bladder irritants is a big one. What the kids are eating and drinking that might irritate the bladder more. So caffeinated drinks, typically most kids aren't drinking a lot of caffeine unless it's with soda. I will mention that a lot of people don't realize that there is caffeine in Starbucks Frappuccinos and even the refreshers. A lot of people think, oh, that's just a fruit juice. No, it does have caffeine in it. And I have had several, usually teenage patients coming in saying that they do drink a lot of Starbucks Frappuccinos and refreshers. So that's one thing to consider. Another big one is chocolate. So chocolate's in a lot. It's a sweet treat. A lot of people really like chocolate. Children love chocolate, and that can be a bladder irritant. So that's one thing that you want to consider. Carbonated drinks is another one. And then some of the things that are irritating to some bladders are things like citrus fruit, sugar, artificial sugar, dairy even can be an irritant to the bladder, tomato products, and spicy food. We're really looking at what is acidic and what is going to cause the urine to be more acidic, and therefore the bladder gets more irritated and is a bit more eager to get that urine out. So potty training. Now, I don't claim to be an expert in potty training, but I feel like there's several good tips out there to keep in mind. One is, when is your child ready? So it's typically between 18 months to 3 years old. You want to see that your child can keep a dry diaper for 1 to 2 hours, usually more towards the 2-hour mark. That they are fully capable of using the toilet. They can sit down and they can stand up. They have core strength to be able to sit on the toilet for a few minutes. That they can follow directions. Are they even aware that their diaper is wet, or if it is soiled and poopy? Can they tell you that? That's a big one. You really have to make sure that everybody's on board, that all caregivers, and that's not just the parents, but that's anybody else who might be caring for the child, babysitters, grandparents, daycare, nurseries, it's preschools. You need to be aware of what the policies are with those, but also what are they going to be able to assist with. And everybody really has to be ready for accidents and mentally prepared that they are going to happen, and they're going to happen a lot. And so just make sure that you're ready for it and that you're going to be okay with it. And try to avoid stressful times like moving house or welcoming home a new baby. I know a lot of moms think, well, I'm home right now, it's a perfect time, but it's a big transition for kiddos, accepting a new younger sibling in the house. So it's probably not a great time to potty train. So when you're starting potty training, you want it to be a very positive experience. So you've got to be happy about it. You got to be excited about it. Make the whole family excited about it so that the toddler can be excited about it. Talk about pee and poo. Don't make it taboo. And I had no intention on making that rhyme, but so it did. And come up with words that you're going to use consistently so the child doesn't get confused between caregivers and parents and school, that everybody's on the same page, and it can make it easier for the child. Have the child watch family members, watch you, watch your partner, watch other siblings, go to the bathroom, make it a normal and positive thing, that it's not a scary thing, and that it's something that they're going to be familiar with when it's their turn to go. Use reward systems as you're comfortable. Every parent's going to be a bit different on what they're comfortable rewarding their child for. But again, make it consistent and start off by just rewarding them for telling you when they've gone in their diaper. It doesn't even have to be that, oh, do you need to go? If they just tell you, hey, I have in my house, we say, oh, I have a wee butt. And so, whatever works for you and your family to help the child say, hey, something's going on. My nappy, or sorry, I say nappy because my husband's British. So, oops, where did I have managed to go all the way back. Sorry, guys. There we go. So yeah, in our house, we use the term nappy instead of diaper. So anyway, so help your child sense wetness. So that's a big one. Diapers are very absorbent, and so they've been wearing them since day one. So it can be a very different thing for a child to understand when they are wet. So it might be wise to occasionally put a folded paper towel in the diaper so that way they can help feel that there is something different when they do urinate in their diaper. But do make sure that that's not something, because it's not as absorbent, you have to check it a bit more frequently to make sure their skin stays safe. So you can also take a poopy diaper to the potty, and if you're able to, drop some in the toilet just so the child knows, hey, poop belongs in the toilet, and make it a big thing that they're taking it and they're going to get to flush it down the potty where the poop needs to go. So whatever you can do to really make it a positive experience is important. So some of you might be watching that have kids with special needs, and I think it's really wise when you're thinking about potty training to really talk with their support team. So there might be doctors and specialists, different therapists, ABA teachers, preschool teachers, psychologists. Really try to bring everybody in and see and try to get on the same page of when your particular child might be ready to start potty training and what are going to be the barriers that you might find for your child. I find that the other parents with children of the same diagnosis can be very helpful, and also, there's usually lots of resources out there if for the more common diagnoses like autism or Down syndrome, that you're going to be able to find resources out there for potty training these children, because we can't expect it with most of them. So some of the common things that we see in pediatric pelvic physical therapy, and some of the common problems that a lot of parents might find with their kids is bladder leaks. So a big one that people know of is bedwetting. So bedwetting occurs because the bladder isn't stretching enough, and it might be reflexively contracting as soon as it feels a stretch. So that might be a cause. The child might be producing too much urine. We're going to talk a little bit more of that in a second. And or the body is just not sensing when the bladder's full and waking the child up. and telling them they need to go. Some of the common things that bedwetting is associated with: constipation. You're going to notice that constipation is a general link in almost every single bladder problem that I talk about today. Constipation is a big one. Urinary tract infections or bladder infections can definitely contribute. Diabetes, whether it's been diagnosed or not. Sleep disorders. So when we sleep, our kidney production slows down. And there's a hormone that is put into the body that helps to slow that kidney function down, so there's less urine production. But if a child is not getting adequate sleep, if they're not reaching deep sleep, they're not going to be producing this hormone. Therefore, kidney function is going to stay high, and the child's going to be producing more and more urine than their bladder is going to be able to take. There is a strong family link with bedwetting. So if I believe the stat is if one parent was a bedwetter, a child has a 40% chance of being a bedwetter. If both parents were bedwetters, they have a 70% chance, or maybe even a little bit more chance of being a bedwetter. So there's a strong family link in that too. So daytime leaks when the bladder is leaking uncontrollably. There are a few different types, which this is the same for adults. There's stress incontinence, when a physical exertion like a cough, a sneeze, running, jumping, sports, a big one's gymnastics. Get a lot of gymnasts that come in with stress incontinence, causes a small or a large leak. Then there's urge incontinence, where you get a bladder leak with the urge to go. And then you can get mixed incontinence, where you get a little bit of both. The common things associated with daytime leaks can also be constipation and urinary tract infections. So some of the simple strategies to help with bedwetting, first of all, is 1, limit fluid 1 to 2 hours before bed. Make sure the kid uses the bathroom right before bed. Next is limit bladder irritants and salt intake. That list that I talked about before with hydration, make sure that those things are not coming, especially right before bed. But even if the body has ingested a lot of salt, that can increase fluid, and then the kidneys are trying to work harder to help excrete that. So you might want to look at what your child is eating and drinking. A bladder diary is a great idea because you're going to be writing down how much a child's drinking, what they're drinking and eating, as well as how often a child's going to the bathroom and if they've leaked or not. So you can on your own just try to draw some correlations that might be causing the bedwetting. If you do suspect your child could be constipated, then you want to go see your doctor. If there's no change with some of these simple strategies, you probably want to go see your doctor too. For daytime leaks, some of the simple strategies that you can use to help eliminate daytime leaks is make sure that your child always takes adequate time to empty their bladder. Monitor their fluid intake, make sure that they're getting adequate amount of fluid, and there is a happy medium. So there are children that sometimes, especially if there's a history of diabetes there, they might be drinking a lot of fluid to help maintain homeostasis. So so you have to watch how much your child is drinking. Limit bladder irritants again. Do a bladder diary, assess when they tend to be leaking, get a good idea of when it's happening, especially because if you do go see a doctor about it, you want to be able to give this kind of information to the doctor. And then look, are they going often enough? Kids get distracted. They love to play. The last thing they want to do is have to stop and go to the bathroom. So it's important that you track how often they're going and make sure that they are going and that they're listening to their body when they need to. So for bladder leaks, some people will ask, well, are pelvic floor exercises going to be appropriate? A lot of times, yes, but not always. And with children, because it's a lot harder to understand what's going on, I highly recommend not asking children to do Kegel and pelvic floor exercises right away without some kind of medical advice or supervision. Strengthening is not always appropriate, and we might need to learn how to relax the pelvic floor more than anything. So if you suspect that there is a muscle component, you or the doctor, I would highly advise getting to see somebody like me, a pediatric pelvic physical therapist. And one of the tools that we use is something called biofeedback, which we're going to talk a little bit more about in the next lecture next week. There are lots of great exercises that do help with pelvic floor health. So core strengthening exercises, stretching exercises, breathing exercises. I'm going to go through a lot of this in week 3 and give you guys a lot of good ideas of fun activities that children can do that promote good pelvic floor coordination. If you do decide you do need to go see the pediatrician, they're likely going to test your child for a urinary tract infection with a urine sample. They're also hopefully going to be looking for constipation through an x-ray. That's a big one. In the pelvic PT world, or pediatric pelvic PT world, we are always very skeptical about constipation. Even if a parent says, no, my child goes every single day, they don't strain, and the consistency is not hard, there's still a likelihood that they could be backed up and you just don't know it. So I would always suspect constipation until it's been ruled out by an x-ray. Your pediatrician might refer to a specialist like a urologist or a gastroenterologist, or sometimes a pediatrician might refer straight to pelvic PT if they think that there's a muscle component that a therapist can help with. And then there's various medications that might help with bladder leaks. Overactive bladder, this is something that's going to happen across the lifespan. It's when somebody is too urgent or too frequent with their bladder emptying, and it can be present with or without urinary incontinence. So urgency is when you cannot delay the need to go to the bathroom. We should be able to stand in line in the bathroom if we need to, or finish what we're doing before we need to go to the bathroom. But if a child finds that they can't, then we would consider that to be urgent. Frequency is when the desire to void occurs more often than is expected. So usually with something like overactive bladder, the bladder is not stretching quite enough, and it might even be reflexively contracting, which could result in a leak. Bladder urge should, as the child ages, it really should become less and less of an emergency. Don't let urgency and that running to the bathroom become a habit. As they get older and they seem to have more control, then really let them gain that control in a healthy manner. Again, we don't want to let them ignore the urge because it is important to empty your bladder, but we don't want the child to always think of bladder urge as an emergency, because that's going to lead to problems down the road. So a simple strategy for overactive bladder is going to be, first, if the child says I need to go to the bathroom, then stop what you're doing. Have the child take some nice deep breaths, maybe 5 or 6 deep breaths, maybe even sing a little song, and then walk calmly to the bathroom, because we need to teach the bladder that it's not in control, and that it is under control of the individual. And so you need to teach the child by slowly getting them to calmly walk to the bathroom is important. Those deep breaths are a really important strategy. And that's something I'll be demonstrating in the week 3 lecture. At times, bladder retraining or timed voiding may be necessary. That's something really that should be done under the guidance of a medical professional like a doctor, or as physical therapists, we also do that a lot. And there are cases where medication is needed for overactive bladder. So the last major bladder problem that we tend to see is something called dysfunctional voiding. This may or may not be associated with leaks, but what it's going to manifest as is an abnormal urinary stream where it's slow, it stops and starts, it splays abnormally. Hesitancy, so if a child has difficulty initiating the urinary stream, or if they feel like their bladder empty or didn't empty all the way, the flow stopped too early and they still feel like they need to go. Or post-void dribble, where the flow stops, you wipe, you get dressed, and or you even just simply stand up off the toilet and there's a little bit of a leak right afterwards. That's another sign of dysfunctional voiding. The cause can be an anatomical abnormality, or it could be a poor relationship between the bladder and the pelvic floor muscles. Remember, those two muscles are antagonists. They don't want to contract at the same time. But in dysfunctional voiding, it could be the case that they are, in fact, contracting when the other one is contracting, which results in a poor urinary stream. Some simple strategies to start off with, if you notice some of these things with your child, is make sure that your child has plenty of time to void. Don't rush them. Don't encourage them to strain and push their urine out. If it's important that they try to sit on the potty. That does include boys. If they're having these problems, have them sit down, because that's a great way to get the pelvic floor muscles to fully relax. You can try deep breathing activities or relaxation activities with them. Make sure if they are sitting that their feet are fully supported. We're going to talk more about toileting posture next week with our bowel lecture, but just as a side note right now, for bladder health, it's important that their feet are fully supported. So watch out if your child is using a big adult potty. I do see a lot of teenage boys with these problems, and so we end up working a lot on toileting posture and breathing activities, relaxation activities. If these problems persist, it's really important to see a pediatrician to make sure that they rule out any of those anatomical abnormalities, neurological causes, and they might end up referring you to physical therapy. So to kind of tie up everything, is one thing you might have noticed in a few of the common bladder problems is constipation's a big one. Like I mentioned, kids can have a regular and soft bowel movement and still be backed up. So really an x-ray or any form of imaging is going to help us rule that out. And so it's an important aspect of what we do. We do a lot of constipation management. And the reason constipation can be so bad to the bladder is because the bowel filling up with stool will press on the bladder, which can either limit its capacity or it could dull its sensitivity, and then the child just does not realize that they need to urinate. So next week we're going to be doing a lot more constipation work.
Yeah, but that's once.
Talking about that. So join us next week for that.